and reliability of the history was good. Presented with the chief complaints of loose stools for 1 year, abdominal pain for 3 months, and loss of weight for 3 months. History of present illness. He was apparently normal until October 2024 when he developed blue stools, which was insidious in onset with stool frequency of 4 to 5 per day, with watery consistency, Bristol stool chart scale of 6 to 7. It was occasionally large volume type and occasionally small volume type, with nocturnal bowel movements of 2 to 3 per night, and it was relieving transiently with oral medication. So there was no relation to meals. It was not associated with the blood or mucus, urgency, tenesmus, joint pain, skin rashes, oral ulcers, or painful red eyes, or perianal swelling, pain, or discharge. From first week of September 2025, he noticed pain abdomen, which was insidious in onset, colicky type of pain, non-radiating, intensity of VAS 5 to 6, lasting for minutes, associated with abdominal distension and gurgling, relieving with passage of large volume stools. He also developed fever, which was low grade, predominantly at evening, associated with dry cough. In October first week, he noticed sudden severe pain localized to right lower abdomen with high grade fever and chills requiring hospitalization. There was no relation with food intake. It was not associated with vomiting, ball rolling sensation, or sensation of lump. He also complains of fatigue and had to stop going to work and occasional giddiness. During this period of illness, he had a loss of appetite and lost 17 kilogram of weight. He consulted a local physician who evaluated him with ultrasound, CT, and referred him to a higher center. He was also told to have less blood and given iron injections. No history of blood transfusions. So he came here with this history. He was evaluated here with CT. He told he underwent an aspiration from his abdomen, and there was no fluid during the procedure. He was managed with oral and IV medications. He did not require any nasal tube placement during this hospitalization and got discharged. After discharge, his appetite improved, fever reduced, however, pain reduced only partially, so he came now again. Past history, he was recently diagnosed with type 2 diabetes mellitus and is on oral medications. There's no history of systemic hypertension, hypothyroidism, or prior surgeries. Personal history consumes both vegetarian and non-vegetarian foods. Is habitual pan chewer, no alcohol or tobacco addiction. So dietary recall, calorie requirement was 1800 kilocalorie and is taking 1300 kilocalories with a deficit of 500 kilocalories. Protein requirement was 60 gram. He's taking 35 grams with a deficit of 25 gram. Family history, no history of similar illness in the family or tuberculosis in the family. My summary, my patient, 56 years old male, recently diagnosed type 2 diabetes mellitus, presented with chronic large bowel watery diarrhea of 1 year duration, colicky abdominal pain and low-grade fever with significant loss of weight and appetite for 3 months, which was followed by a severe pain localized to right lower abdomen with high-grade fever and chills, requiring hospitalizations, iron infusions, IV medication, with failed single-time aspiration, with no history of blood transfusion or symptoms of malabsorption. My syndromic diagnosis is chronic painful large bowel watery diarrhea with partial bowel obstruction and probable contained perforation. I would localize the lesion to be at ileocecal or proximal ascending colon. So I would consider benign over malignant syndrome in my patient. My first differential is ileocecal tuberculosis. Second would be ileocecal Crohn's. Third would be carcinoma of proximal right colon, either cecum or ascending colon. Fourth would be ileal lymphoma, and fifth would be ileal NET with complications of malnutrition and anemia. Comorbidity of type 2 diabetes mellitus with an ECOG performance score of 1. So points favoring tuberculosis include fever.
Hold on. First, we will go back to the history.
Yes, sir.
So you described diarrhea as watery diarrhea.
Yes,
okay. So generally it creates confusion. So it is not proper to use the watery diarrhea because are you aware of how do we classify watery diarrhea? Some of the guidelines.
Uh,
Have you read any of the chronic diarrhea guidelines?
it is either osmotic or secretory diarrhea, sir.
No, I'm talking of direct guideline. That is pathophysiology. That is written in the Schlesinger. That is all right. But I'm directly asking you: are you aware of the any of the published guideline? One of the published guideline is quoted in Schlesinger, but there are other published guidelines.
I am not aware, sir.
Not aware. So it will be very useful if you read at least 2 or 3 guidelines on chronic diarrhea, because you don't have too many guidelines on chronic diarrhea. So one leading guideline, which is quoted in Schlesinger actually,
Okay, sir.
is AGA guideline. Okay, so that is very old. In 90s, it came, and subsequently in I think late I think 2018 or somewhere, they reiterated the same, that they will persist with the same. So that classification is very popular, very handy, and extremely useful clinical classification. So that helps a lot to decide initial part. So that classifies only in three subgroups. Very simple classification.
Okay,
So
sir.
watery diarrhea, fatty diarrhea, and bloody diarrhea. Okay.
Okay, sir.
So you have to take. And what is the aim of this classification?
To
So if you read that guideline, then it will become apparent. The aim of this classification is to pick up the workup algorithm. So each syndrome, if you see in the Schlesinger also, or if you go to the main article, so that is followed by a tail, which is basically algorithm for the workup of that patient. So based on the history, you will decide whether this is watery diarrhea, fatty diarrhea, or steatorrhea. Okay. So when
okay,
you clinically say that this can be used, slightly more elaborate, there was one Beijing guideline which was didn't become popular because that was essentially mess of everything. So that created eight, 9 categories. So that was not useful. So didn't become popular. Now we have BSG guideline, British Society Gastroenterology guideline. That is the last one. So that is useful. They have done some improvement over the previous one. So there is a little advantage. So that all those nitty gritty, if you read those articles, then you will be able to make out. So that's why it is very important. Then when you describe consistency, you describe as a fluid, or
yes,
Bristol score you described, that was fine. But liquid word you should avoid, watery word you should avoid, because that is basically audience, the listener will consider that you are suggesting that this is chronic watery diarrhea, which may or may not be. Okay, so that
okay, sir.
is part number 1. ठीक है? So that was the word which I thought. The second part, when did it start? It started in October 2024.
Yes, sir. October 2024.
Hello.
Yes, sir. October
So
2024.
that is
1 year back, sir.
so October 2024. That is more than a year back.
Yes, sir.
So where is the course of this diarrhea?
Sir,
You
it is.
described which appeared like at onset you are describing,
Yes, sir.
and then you it seems that information on the course is completely missing.
Okay, sir.
So that will not be proper, because we gain much more information on the course, what is happening over a period of time. It is going, no diarrhea will go like that, na? That it's continuously going a stool frequency 4 to 5, and like that. So you didn't talk about the course, that what is happening. This is waxing, waning, intermittent sometime, improved with the treatment, not improved with the treatment, because your patient is diabetic.
Yes, sir.
So diabetic, you understand there are certain causes of diarrhea. Those drug-induced causes, as well as SIBO, those things will come up, and which will the treating physician will give a course of antibiotic. Diarrhea improves, remains well for 4 weeks, 6 weeks, 8 weeks, and then it recurs. So that information will come only in the course. So that is not coming up.
Okay, sir.
So that is very. So basically, you understand that when you start with diarrhea, first effort should be you cone down whether you are dealing with organic diarrhea or functional diarrhea. So what is your interpretation here?
Sir,
Organic diarrhea, functional diarrhea.
organic diarrhea, sir, as per my history, since
Based on what?
sir, it was
How do we
associated.
make?
Yes, sir. It was initially painless, but later he went on to develop pain abdomen with nocturnal bowel movements and significant loss of weight.
Does pain make a distinction between organic and functional diarrhea?
No, sir.
No. So why did you pick up this point as a first point? First point you will pick up as the which is strongest point. Na?
Loss
You
of
will
weight.
not
No.
put the weakest point.
Yes, sir.
So pain, you know that IBS is a prototype of functional bowel disease or functional diarrhea. IBS-D will be functional diarrhea.
Yes, sir.
Okay. And
Yes,
you know that the pain is the cardinal symptom in case of IBS.
yes,
So
sir.
pain doesn't make a distinction. So tell me what makes a distinction between the bloody organic diarrhea and functional diarrhea.
Sir, here my patient is having nocturnal bowel movements, sir, which points strongly to organic illness.
Which points, but I will differ strongly. Nocturnal bowel is a mentioned in all textbooks, all review articles that generally that signifies. But when you take the nocturnal symptom history, then you have to be slightly more, do little more digging.
Okay, sir.
Nocturnal patient understands nighttime any movement is nocturnal, whereas for our purposes, what we mean by nocturnal,
He has to wake up from his sleep and
that is very important. So
yes,
he goes to sleep and gets awakened because of urge for the
bowel
stool,
movement.
urge for passing stool. Okay,
Yes, sir.
so that should be clarified very clearly. You are not talking of nighttime movement. You are talking of, so he used to be awakened two three times or one time or something like that during night from the sleep. ठीक है?
Okay, sir.
So but that is still it is a relatively softer point. What is
Okay.
the hard point in case here?
In my
In
patient, during the course of illness, he also developed a significant loss of weight and appetite, sir.
So that is very important. Now you have quantified. So if you would not have quantified, then we would have thought, okay, it may be significant, it may not be significant. Only when you quantified, you didn't quantify the time with it. Generally, whenever you quantify weight loss, you always put a timeline on that.
Yes, sir.
So it is not clear to me that like we are talking of long period of time. We are
Yes, sir.
talking of almost 14 months. So it might have been that she has lost whole of weight in last 3 months only or last 6 months only. So whether this is linear weight loss or this is over total period, if you are talking, then you should clarify. Okay.
Uh,
So when you talk, so when you
he,
talk,
sir, he actually developed, he noticed weight loss in last 3 to 4 months only, sir.
so now you are clarifying. Na? So you should have mentioned early that 13 kg or 14 kg weight loss, which predominantly happened in last 3 months time.
Yes, sir.
So that would have made it more, that will carry more weightage. Okay.
Okay, sir.
कि 3 months में 14 kg and versus 14 months में 14 kg. You understand the difference,
Yes,
na?
sir.
The huge difference. So that is very, very hard point to make a distinction between the organic and functional diarrhea. So here we have 2 points. One is nocturnal symptom and the second is weight loss. And third, any other point?
He also had a high grade fever, sir.
Fever, newer symptoms are appearing. She is becoming sicker and sicker because earlier she didn't have much of those symptoms, na? Fever and other things. Na?
Yes, sir. Yes,
So
sir.
new symptoms. So generally in functional diarrhea, it will not happen. So when you describe, your every effort should make a distinction between the functional and organic. So the listener should clearly understand that you are talking of functional diarrhea. There is possibility of functional diarrhea or not, and there is possibility of organic diarrhea or not. Okay, or both.
Okay,
If
sir.
sometimes it is not very clear, then you will go by like that. And then when you go to uh, organic diarrhea, then again we will try to fit into the syndrome, whichever guideline you want to face. So it is a very common mistake, and you have also made this mistake. So don't try to make a cocktail of different ways of classifying and make a mixture out of it. Okay, so if
Okay,
you
sir.
want to follow BSG, follow BSG. If you want to follow AGA, it is okay to follow AGA, but because your textbook is following AGA, so I will suggest for exam purposes, may not be in the clinic, but for the exam purposes, it is better to stick with the AGA because that is easy and simple.
Okay,
So
sir.
you will classify. So here you will classify out of three types of which we talked. AGA classify watery diarrhea, fatty diarrhea, and bloody diarrhea. So why do you say it is which group it belongs to?
It is in my patient. It is water diarrhea, sir. It is
It is
not fatty because it is not greasy. Patient did not have any difficulty in flushing out stools, and it was not associated with foul-smelling stools. And it is not bloody because it is not associated with the blood or mucus. There was no urgency or tenesmus.
hmm,
So, and consistency is also in BSS 6-7. I'm keeping it as a watery diarrhea, sir.
keeping it as a watery diarrhea. So this is a myth. Okay, when you say that fatty diarrhea, you always say that there should be history of steatorrhea. It is not like that. Okay, so
Yes.
basic they chronic diarrhea with malabsorption or chronic fatty diarrhea or chronic diarrhea with steatorrhea. Steatorrhea is just one component of that because basically there will be malabsorption of multiple nutrients. So what is happening in your patient? Your
He
patient is
did
your
not give.
patient has lost 13 kg weight.
Yes, sir.
Okay, this weight loss can be because of reduced intake, or this weight loss can be because of catabolic state. Okay, which
Yes, sir.
will depend on the etiology. Okay, so
Yes, sir.
or because of malabsorption. So if you want to consider that this is occurring because of malabsorption, so even that diarrhea you can classify as chronic diarrhea, chronic fatty diarrhea. So you will say that there is no overt symptomatically because unless there is gross steatorrhea, that history may not come. But if you do investigation, you will still find evidence of malabsorption and fat. So that is a misconception. So that should be clarified. So you will say that overt steatorrhea is not there, but still patient can be having biochemical steatorrhea. Okay, so that is important.
Okay, sir.
Similarly, in bloody diarrhea also, it is not essential to have naked eye blood. Okay, so patient reports that blood is mixed with a stool, only then you will classify. Okay, if you have surrogate markers, some surrogate markers which says that okay, this can be bloody diarrhea. Sometimes it says that some little brownish, little reddish color comes, multiple frequency, lots of rectal symptom is there. Then still you can classify. Okay, but what will be
Okay,
the
sir.
hard point for classifying uh, bloody diarrhea?
Um,
Hard point for classifying bloody diarrhea. So if you see the algorithm, that there will be a tail, and based on what will be classified as bloody diarrhea. So there are 2 points in to classify bloody diarrhea. One is you do a stool examination, find lots of RBC or pus cells.
okay,
Okay,
sir.
I repeat, RBC or lots of pus cells. Then you will classify as fatty diarrhea. So दोनों होना जरूरी नहीं होता है.
Okay, sir.
Okay. So even one is there. Or you have lots of or some inflammatory markers, say for abhi calprotectin, lactoferrin, MPO, myeloperoxidase, any of those parameters are positive, then you will consider that okay, this is inflammatory diarrhea. Okay, so that
Okay,
will
sir.
be based on limited investigation, very limited investigation.
Okay, sir.
Okay, so that myth should go away.
Yes, sir.
So then, whenever we talk of watery diarrhea, we try to make a distinction. If you see AG algorithm, then it will classify into two groups. Like you are considering here, picking up subset of watery diarrhea.
Yes, sir.
Okay. So then it says osmotic diarrhea and one is secretory
Okay.
diarrhea. So what do you consider? What are you considering here?
Sir, my patient diarrhea, there was no any significant relation with a meal, sir. So I
Does
would,
it make a distinction? Relationship with the meal make a distinction between osmotic diarrhea and secretory diarrhea?
sir, osmotic diarrhea usually precipitated by food intake, sir, whereas secretory diarrhea, it won't, I mean, on fasting, osmotic diarrhea comes down, whereas secretory diarrhea won't come down, sir.
The second statement or second clause is possibly partially correct. The first clause is, I think, is not correct. So relationship with meal has nothing to do with the osmotic diarrhea or secretory diarrhea, because the whole bowel is how? What is the length of bowel? Small bowel and large bowel.
Small bowel 600 to 800 centimeters, sir. Large
600 to
800 centimeters, sir. 800 centimeters, sir. 600 to 800 centimeters.
okay. So
Large
that is
bowel, large bowel is around 150 centimeters, sir.
ना थोड़ा सा और बढ़ा दीजिए, increase it little bit more. ठीक है. So that is a long length to cover. So food pain, how does food pain, food and bowel movement relationship happens?
Gastrocolic reflex, sir.
Gastrocolic reflex. So gastrocolic reflex is not always pathological. When it gets exaggerated, when we take in favor of like IBS, you always talk of prominent gastrocolic reflex, but it is not always pathological. Okay,
Okay, sir.
so watery diarrhea, you talked about the fasting. So how
Yes.
do you take history of your description when you were describing? You never talked of effect of fasting. So that effort should have been made, because if you are going to make a diagnosis, every effort should be make it to make the distinction between the two subset, whether
Yes.
this is secretory or whether this is osmotic.
Okay, sir.
So did you take history of effect of fasting?
Fasting I didn't take, sir.
So that should have been there, na? Because that is a major lacuna which crept into the history. So how much fasting is fasting for this purpose? Patient 6 hours, 8 hours, 12 hours, 24 hours, 48 hours, 22 hours.
Sir, more than 24 hours fasting, sir.
How did you decide? I just want to understand. You read somewhere, or yeah, good guess or bad guess, or based on some physiology?
Guess only, sir.
Guess only. So guess based on physiology or something. What is the normal orocecal transit time? What is colonic transit time? So these come very handy when you are talking of case like diarrhea, malabsorption. Then little bit of understanding of GI physiology is very important. Okay,
Okay,
your
sir.
answer is correct, but mostly we rely 24 hours is not a very sensitive, very good marker, but if 48 hours is better marker.
Okay, sir.
Okay.
Okay.
So generally 48 hour mein agar if diarrhea is not improving, we tend to think of secretory diarrhea. And what are the examples of secretory diarrhea and what are the examples of osmotic diarrhea?
Sir, osmotic diarrhea can be lactose intolerance or ingestion of sugar alcohols, laxatives like PEG, magnesium sulfate. All these comes under osmotic diarrhea, sir. Secretory diarrhea can be due to infectious causes. It can be due to neuroendocrine tumors, or it can be due to endocrine causes such as hyperthyroidism. It can be also due to immunological causes like CVID, or can be due to infiltrative disease like amyloidosis, sir, or multiple myeloma.
अमाइलोइडोसिस में कैसे secretory diarrhea कैसे होगा? Amyloidosis?
Sir,
Secretory diarrhea, amyloidosis.
sir,
So what I'm trying to do, you understand?
Yes, sir.
I'm trying to check your preparation for exam, and this is what you need to be prepared. That at one point or the other, in almost virtually every exam, you will get stuck on a question. Okay, and then you have to come out from the question by somehow or other. This is called wriggling out. Okay, so you have to wriggle out of that. The
Yes, sir.
most direct method of wriggling out, sir, I'm not able to recall at the moment. Okay, that is the most direct, crudest way.
Okay, sir.
Okay. So don't get stuck there and holding on. Examiner is staring at you. So that is usual exam tactics. Okay.
Okay, sir.
So half of it exam is drama and practice and style of presentation, way of presentation. So this is wriggling out. You should be always ready. That okay, if I get stuck, how will you wriggle out? So it is not that one strategy will help you always, but you should have 3-4 strategy ready in your mind. That if I get stuck where I don't have idea, I don't know the answer, examiner is insistent, then how will I wriggle out? So it is very important and it comes by practicing. But before practicing, you need to make the strategy in your mind. Okay.
Okay, sir. Okay, sir.
So here you got stuck. So you will say, ki, okay, the decent way which saves your dignity and which saves examiner's dignity. That okay, sir, I have read, but I'm not able to recall it now. Okay.
Yes,
So
sir.
that is a decent way of saying it. So you save time on that, so that you get more questions and more opportunity to answer those questions. So
Okay, sir.
otherwise, if you lose all the time on this getting stuck, then you don't get opportunity to answer those questions. Okay.
Yes, sir.
So proceed on. So that we analyze. So now we are, I think, one step we have covered. So we are at the stage of uh, watery diarrhea, and you want to consider here osmotic diarrhea,
Uh,
secretory, secretory diarrhea,
Secretary diarrhea, sir.
secretory diarrhea. Okay. So then I will like you to
Not,
analyze each component of the history and
actually, my
interpret.
not strongly favoring osmotic or secretary from the history I've elicited, sir.
Not so you don't want to, you want to remain non-committal. That okay?
Yes, sir.
Uh, it can be either or it can be mixed.
Yes, sir.
Okay, so that you should have picked up from the very beginning. Okay, so
Yes, sir.
now I'm asking you to analyze the history. So what is happening? So analyze the history when such a question comes, then you will pick up in chronological order that the first symptom, what is the meaning of the first symptom, and then another symptom got added in this patient. So what is the meaning of that? And then sequence of event, the way sequentially it progress, so that you will try to explain.
Okay,
So
sir.
try to explain that. So analyze the history part now.
Sir, my patient, he 1 year back, he developed having this loose stool, sir, diarrhea, which was initially, insidious watery 4 to 5 episodes per day. So since it was large and small volume combined along with the nocturnal bowel movements, I think it is organic diarrhea, and I probably would localize this diarrhea to either internal ileum or proximal small bowel, sir. And
Have
as
you have you read anything which
proximal large bowel, sir.
so have you read any in your textbook what makes a distinction between terminal small bowel diarrhea and colonic diarrhea? So it will be extremely difficult. So basically you will say that there are features of large bowel, but there are also features of a small bowel. And obviously when there is so much of weight loss, then
Yes, sir.
it will be difficult unless you consider catabolic state, malignancy, and those things, to explain only with the small bowel, or only with the large bowel. ठीक है. So you
Okay,
will
sir.
say there are overlap features of small and large bowel type of diarrhea. ठीक है,
Yes,
accepted.
sir. Yes, sir.
Okay, then
Then he went on to develop abdominal pain, sir. So, which was colicky type of pain. Associated with abdominal distension and relieving with passage of large volume stools. So, I would consider luminal pathology, probably obstruction, intraluminal, sir. And would locate it probably to large bowel as there was predominantly abdominal distension, and there were it was relieved with the passage of stools, and there were no history of vomiting. So I would locate it to large bowel or IC junction luminal pathology, obstructive pathology, sir.
when I'm reading the slide which you are showing, it seems that you have not worked upon preparation, that how you are going to describe each symptom. So when in the residency days, when we were doing residency, we always used to be ready that, okay, when I'm going to describe abdominal distension, I'm going to describe abdominal distension on that many heading, whether it is diffuse or localized to one quadrant, persistent or intermittent. Okay, so
Yes,
similarly,
sir.
pain, we used to say that we will describe it in 14 headings. ठीक है, mean, side, radiation, character, duration, frequency, aggravating factor, relieving factor, other associated symptoms, that type of thing. हर किसी का एक अपना एक्रोनिम होता था. ठीक है,
Okay, sir.
कोई
Okay, sir.
कुछ ना कुछ एक्रोनिम. अब if you see, the pain description is not complete. ठीक है, so tell me first, this is visceral pain or somatic pain?
This is visceral pain, sir.
Visceral pain. Why do you say so?
Since it was colicky and located over periumbilical area, and
So दो चीजें हो गई ना. Though that doesn't make a clear cut distinction. The most important point है, if it is localized to a narrow area, very localized type of pain, that is generally will be somatic pain, and the visceral pain will be always diffuse type of pain.
okay, sir.
Okay.
Yes,
And whenever you say colicky, the moment you say colicky, how do you recognize colicky pain? First, one question. And the moment you say colicky pain, you are bound to report the frequency. ठीक है, because
yes, sir.
colicky pain is typically, colicky pain is what? It is crescendo decrescendo type of pain.
Yes, sir.
Okay.
Yes, sir.
So you are bound to describe the frequency, that what is the frequency, how long does it last?
Yes, sir.
How long does it last?
It lasted. It was lasting for minutes. 2 to 3 minutes is what my patient told, and at a frequency of 2 to 3 times initially during the course of illness, sir, which went on to.
So that description should have come, na, that it was a crescendo decrescendo type of pain occurring with a frequency of 5 pain episode per hour, and occurred several clusters occurred each day,
Okay, sir.
and such an episode lasted for 7 days, 10 days, 1 month, 2 months. It required analgesic or not, that is important, na.
Yes, sir.
And will you tell what should be the build up time? So crescendo decrescendo pain, how much time it will take to build up, and how much time will it take for relief?
Sir, it takes seconds to minutes to relieve, sir.
And build up.
Build up, I am not sure, sir.
So do you have any idea why colicky pain happens?
Bowel tries to overcome the obstruction, sir. So proximal to the bowel, there will be increased peristalsis. So that is responsible for the colicky pain, sir.
So the way you are answering, na, it lets me think that you possibly have not a clear concept of bowel motility. Okay, so small bowel motility, when you talk of motility, you talk of what is peristalsis. Peristalsis is a ring contraction preceded by a wave of relaxation. ठीक है, so wave of
Yes, sir.
relaxation पहले आती है, फिर ring contraction आती है, और फिर ring contraction खत्म हो जाती है. तो ring contraction में दो चीज होगी ना, कि एक amplitude of contraction होगा और एक duration of contraction होगा. तो whenever there is obstruction, the amplitude increases and the duration of the contraction wave also increases. So peak becomes broader, the peak becomes higher, and the frequency becomes more. Okay, so it will
Okay.
be crescendo decrescendo occurring over a period of minutes. It will be not over period of hours. ठीक है, 1 hour, 2 hour, 3 hour, 4 hour में एक पेन हुआ एपिसोड, फिर ठीक है, और फिर 4 घंटे के बाद हो रहा है ना. कोलिकी पेन को ऐसा नहीं होता है. कोलिकी पेन क्रिसेंडो डिक्रिसेंडो will happen over period of minutes. So that description should come.
Okay, sir.
And the most important, that colicky pain, you have not mentioned the site here. The
Yes,
site,
sir.
you understand that when we talk of visceral pain, we always talk of foregut, midgut, and hindgut. So where will be the foregut located? Pain?
Epigastrium, sir.
Epigastrium. And midgut, hindgut?
Midgut periumbilical, hindgut hypogastrium, sir.
So that is one way of जो classic teaching है, but there is another way of looking at it. So you'll draw a oblique line from left hypochondrium to right iliac fossa. So foregut and midgut pain will be towards the right side, and the hindgut pain will be towards the left side. So okay, that is also one way of looking at it. You
Yes, sir.
understand?
Yes,
You
sir.
divide the abdomen from left hypochondrium to right iliac fossa, oblique line, and the hindgut pain will be towards the left side, and foregut midgut pain will be that side. So because this was a very crucial point for interpretation of this patient, so because sight is missing and the visceral character you are not clearly mentioning, but by virtue of colicky nature, we presume that this is visceral. ठीक है? Then
Okay, sir.
disappearance also is important. ठीक है?
Yes, sir.
So gurgling you described is important, but you also describe gurgling and relation of the crescendo thing, crescendo of pain. If gurgling is happening during crescendo, that is much more relevant, because increased peristalsis will lead to gurgling.
Okay.
So you will say that the gurgling and the peak of pain was related. ठीक है? And how do you make a distinction? How do you decide that this is distal small bowel or versus proximal small bowel?
Distal small bowel pain will be relieved with vomiting, sir. Whereas, I mean, proximal small bowel, sir. Distal small bowel or large bowel, it will be more of abdominal distension and relieving with passage of stool, sir.
Passage of a stool तो तब होगा ना जब when obstruction is relieved, may not
Yes,
be
sir.
relieved. So that doesn't mean that pain will keep persisting, because ultimately contraction wave has to disappear. Na?
Yes, sir.
It cannot.
Yes, sir. Vomiting
So,
is prominent in distal small bowel or large bowel diarrhea, and abdominal distension is less prominent.
not diarrhea. Diarrhea, it has nothing
I mean,
to do. It
sorry,
has
sir.
to be the obstruction.
Obstruction, sir.
Obstruction. So you are saying, but you are saying the half truth. Quote always say, I will say the complete truth.
Okay,
ठीक है? So what is that if the vomiting is occurring at the peak of pain episode, that is highly suggestive of proximal small bowel obstruction, proximal gut. So basically gut obstruction we classify as gastric outlet obstruction, then is proximal small bowel, distal small bowel, and colonic. Okay, colonic we don't distinguish between right and left colon, because of that will be located in hypogastrium or the area which I described you.
Yes,
And
sir.
then distension will be diffused, and it can get referred even in the right iliac fossa when the obstruction is actually in the sigmoid or rectosigmoid junction. ठीक है? So
Okay,
that's
sir.
why colon को सब segment में नहीं divide करते हैं, but small bowel को proximal and distal. So vomiting is a prominent feature or not, distension is a feature or not. So इसमें दोनों चीजें missing है आपकी.
Sir, distension is there, sir. I mentioned pain is associated with abdominal distension and gurgling. Also, in the next point, I mentioned not associated with vomiting. Sir.
Okay. So no vomiting
No
at
vomiting,
all.
sir. Yes, sir.
So this is proximal gut or distal gut?
Distal gut, sir.
So this becomes distal gut obstruction. ठीक है?
Yes,
So
sir.
from 1st September, so what was the frequency of pain? And did this patient develop obstipation at any point of time?
He did not develop obstipation at any point of time, sir. Starting from October first week, the there was a sudden onset severe pain, which was earlier periumbilical, was now localized to right lower abdomen, sir. Association with high grade fever and chills. So I would, so I think the or disease process has involved from, I mean, initially it was involving visceral peritoneum, then it went on to involve parietal peritoneum.
पेरिटोनियम पेरिटोनियम कहाँ से आ गई? We were discussing into bowel. Peritoneum कैसे आ गई? What is the evidence of peritoneal involvement out here? So far we were discussing a small bowel, large bowel, na?
Yes, yes, sir.
So suddenly you move to peritoneum. How come?
Sir, since pain was the sudden onset pain was localized to right lower abdomen, so I assume that it would have involved the parietal peritoneum at that area. So that's why I mentioned.
No,
Such a manner.
even if it involves visceral peritoneum, still it will get localized. So something happening in the bowel lumen, something is happening in the visceral peritoneum which wraps around the bowel, it will be same. ठीक है, so अभी jump करने के लिए नहीं, आप subsequently will be able to make out, but at this point of time we are discussing. So your basic interpretation, you are not going to that. So you will say process started with which was painless to start with, na?
Yes, sir.
So and remained painless for almost a year.
Yes, almost 8-9 months he was painless.
8-9 months, 9 months, 10 months remained. So that point of time, there over that period of time, there was no significant obstruction.
Yes, sir.
Okay.
Yes, sir.
So you will say that some pathology was going on, so which was not causing obstruction, but because of that pathology has progressed and that has led to obstruction. So September onward, you believe that there was some sort of bowel obstruction, which is possibly distal small bowel obstruction. Okay.
Yes, sir.
So then you have in October, you have sudden onset severe pain localized in the right lower abdomen with high grade fever and chills requiring hospitalization. ठीक है? So what
Yes.
is the interpretation of this?
Sir, so the previous pain was suggestive of obstructive pathology, sir. So now the new onset pain with localization, so I would have think of maybe proximal to the obstruction, some perforation would have happened. That could have caused this localized pain along with high grade fever and chills.
And you think from October first week to November last week now we are. Okay.
Yes, sir. Yes, sir.
So almost 7-8 weeks.
Yes, sir.
So perforation patient goes on behaving like that for 8 weeks without any surgical intervention.
Micro perforations contain perforations, sir, basically.
कहीं पढ़ा है माइक्रो परफोरेशन के लिए?
Sir?
स्लेसिंजर में कहीं मेंशन किया है माइक्रो परफोरेशन?
Contain perforation, sir.
हाँ?
Contained
Contained. So that is typical. That is what is called intraperitoneal abscesses. ठीक है? So you need to make a distinction between penetration and perforation.
Okay, sir.
ठीक है, कहीं भी जैसे अगर डियोडनल अल्सर के लिए जब बात करते हैं ना, तो when we talk of two things ना, one is penetration and one is perforation. ठीक है, perforation is generally anteriorly in the peritoneal cavity, either in the lesser tract or the greater tract, and that will lead to perforation, classic perforation peritonitis. Patient will have to be operated within hours to days, otherwise patient will succumb. Whereas penetrating duodenal ulcer penetrates to the bed, which is formed by the pancreas, and it can go weeks and months altogether. And there may be abscess formation, there may not be abscess formation. ठीक है? Similarly, Crohn's disease, you have penetration here, there, everywhere. Mesentery में कहीं भी हो सकती है. So there can be perforation also and there can be penetration also. So you said perforation, so you should have said penetration because patient didn't become so sick over a period of 7 weeks.
Yes, sir.
Okay, so you should have, or possibly some sort of penetration is occurring because of whatever pathology he or she has, and that has led to possibly intra-abdominal abscesses. So that will explain localized pain. That will explain fever with chills and rigors. Okay.
Yes, sir.
He complained of fatigue and had to go to work. He stopped going to work and occasional giddiness associated with loss of appetite and 17 kg weight loss. So यहाँ पे पीरियड डालना था तो वो रह गया.
Yes, sir.
ठीक है. So मोस्ट इंपॉर्टेंट पार्ट हमने छोड़ दिया इसमें कि लोकल फिजिशियन हु डिड अल्ट्रासाउंड सीटी परफेक्ट, referred to higher center. He was also told to have less blood and given iron injection. No history of blood transfusion. Antibiotic मिला कि नहीं मिला इसको?
Sir,
एंटीबायोटिक्स मिला या नहीं मिला इसको?
actually he told he was treated with some oral tablets, sir. He did not mention any IV injection. Also, he did not know the name of the tablet, sir. So that history could not be elicited properly from the patient, sir.
But he gave you history of IV injection, IV iron.
Yes, sir.
So how can patient give you history of IV iron when he is not able to give other descriptions? So that will question the credibility of history, na?
Yes, sir.
So the common saying is that reward will be proportional to digging. जितना एफर्ट लगाएंगे उसी के अनुसार रिवार्ड मिलेगा. सो अगर आप एफर्ट लगाओगे तो पेशेंट हिस्ट्री दे देगा, ठीक है. IV injections, IV iron will not given daily, ठीक है. और at best if it is given, it will be given as infusion and it will be given once a day only. Okay. Yes. Whereas most of the antibiotics will be given multiple times a day, either oral as well as injections. So if you do enough digging, you will get the history, na? And you don't expect that in such a situation, whatever type of center patient gets treated, he will receive antibiotics. So let's proceed because we have covered, taken lots of time. So make the syndromic diagnosis and etiological diagnosis. So whenever you come to somebody and then make diagnosis, you should always make first syndromic diagnosis and then etiological diagnosis.
Yes, sir. My syndromic diagnosis will be chronic, painful, large bowel, watery diarrhea with partial bowel obstruction and probable.
By the way, what is chronic diarrhea?
Any diarrhea lasting for more than 4 weeks, sir.
And acute diarrhea?
Less than 2 weeks, sir.
2 or 4 weeks के बीच में?
Persistent diarrhea, sir.
Persistent diarrhea. So, okay, so this is chronic diarrhea. So no doubt because she has, because the symptom is for more than a year. Okay, yes, with partial small bowel restriction with contained perforation. So here you don't gain anything out of making perforation. I said you that perforation untreated without surgery 8 weeks is unlikely. So you will say that possibly penetration or intra-abdominal abscess.
Okay, sir.
Okay, so that should have been difference. And level of obstruction?
Ileocecal or proximal ascending colon, sir.
फिर अगर ये ascending colon निकल गया तो इन्वेस्टिगेशन में तो फिर आपकी क्रेडिबिलिटी स्टेक पे होगी बिकॉज द वे वी आर डिस्कसिंग बिकॉज राइट कोलन ऑब्स्ट्रक्शन इज अनकॉमन. व्हाई सो?
Because right colon is spacious, more diameter.
One reason.
So,
second reason,
fluidity of the stools, sir.
Fluidity. So right colon में contents are fluid and diameter is more. So radiologically, what is the diameter of right colon? What is the diameter of terminal ileum? Radiologically.
Terminal ileum around 2.5 centimeters, sir.
Upper limit. So it should be less than, ठीक है. Some places it is said less than 2 centimeter because proximal gut is wider compared to distal gut and the narrowest part is generally terminal ileum. So somewhere it is written 2 centimeter also, especially for terminal ileum. And the cecum ascending colon?
Cecum around 6 centimeters, sir.
Okay, 6 to even 8 centimeter. Okay, so fluid, so their obstruction generally doesn't occur barring special circumstances. And we can discuss, but because we don't have time, so that I would like to forego. And then you want to consider
My first
benign.
benign etiologies I would like to consider first, sir. My first differential would be ileocecal tuberculosis. Points favoring in my patient are the history of fever, significant weight loss, and partial bowel obstruction, uh, colicky type of pain, and with watery diarrhea, sir. All these points are favoring tuberculosis. I could not uh, uh, like find any points which are against the diagnosis of tuberculosis in my patient.
So, two questions.
Yes, sir.
Like this patient remained painless for almost a year.
Yes, sir.
Painless chronic diarrhea.
Yes, sir.
So, how common is painless situation in TB? And the second is how common is perforation in case of TB?
Sir, pain usually up to almost close to 70% have pain in ileocecal tuberculosis, sir. Only 30% are painless. And perforation, I don't have any clear number, sir.
Clear. So, when you prepare for exam, there are two ways of studying. I think if any of one you attended the meeting in Bhubaneswar, there I had taken the first lecture. Then I had explained that how do you prepare for exam and how prepare during study during residency time. So one method is called extensive reading. So extensive reading is good enough for 2.5 years of your training program. And in the last 6 months, when you become exam going, that time you go for intensive reading. So extensive reading is basically you keep reading whatever comes to your hand. So you keep reading that. So that is of two types. You go to library, or you, even if you're in room, you have online access, see a good article, good guideline, and you read that. So that is extensive reading. So randomly you are reading. That is called non-directed extensive reading. Okay? So their retention will be much less. The second component comes is when you do in directed reading. So if you have a patient admitted in ward under you, or if a patient in OPD and you face difficulty, say for now you have PCAB available, you have PPI available, you are not sure that which one to use for H. pylori eradication, or for that matter in peptic ulcer breed, you should be using PCAB or PPI. So you go back to room, you try to read out, solve this problem, that which should be the preferred one, and then you read. So this is called directed reading. During the extensive reading part, this is called directed. So this will be patient directed reading. So here the retention will be much more. So if you practice for 2.5 years directed reading, then the retention will be much more. The moment you come closer to your exam, and most of the time it means that in the last 6 months, then you revert to a different strategy, which is called intensive reading. So intensive reading, what you do, you pick out the cases, you make a list of cases. So like this type, subacute intestinal obstruction and diarrhea. So make up cases, and then you try to make questions on it and prepare on that. So that is one part of the, but the prior to that, you will be ready with some type of performa, which I was talking just now. I don't know you picked up that or not. That like pain, you are going to describe pain in 14 headings. So you should be ready that these are the 14 headings I'm going to use. Right? Lump, I'm going to describe in 12 headings. So okay. 12 headings you should be knowing. So when you will be presenting your case, basically you are scrolling through the screen of your laptop and you are trying to fill. Okay, you are missing the points continuously, like in the pain you missed point. Then other areas also you miss the points. That is because you intensive phase, you have not prepared your performa well. Otherwise, those points will not be missed. So you should be ready for that. So similarly, in the intensive phase, if you would have prepared a case of TB, then you will always see common questions. Na?
Yes, sir.
Common questions out of abdominal TB, what percentage in intestinal TB? How common is intestinal TB associated with peritoneal TB? So combination is how commonly seen. What percentage will be painful? What percentage will be painless? What percentage will have overt bleed? What percentage will have only occult bleed? And what percentage will not have bleed? So these are the common answers. Na? So like there are different series available. So
Okay.
because you have so many TV series available from India, like PGI series, the pain is 100%. Okay, so
Okay.
100%. So agar at presentation, even if not there, the within 3 months, 4 months, 5 months, 6 months, there should have been pain. But there are other series from other centers where anywhere between 60% to 90%. So you said 70%, so that will be okay, acceptable figure. Okay.
Okay, sir.
ठीक है
Okay.
so that is okay, but you should be ready with answer.
Yes,
And
sir.
at DM stage we expect that you will be quoting some of the series, and then when we asked you GI bleed part, you are not answering. So that is so widely available, widely quoted in TV. Almost every series, Indian series, will mention that how much percentage of patients had overt bleed. Occult bleed we will not talk because that will be positive in very high percentage.
Around 10 to around 15% presented with overt GA bleed, sir.
हाँ 15 maybe different series vary करेगी 5 to 15% the overt bleed. And if you say fistulation, we have from our center especially addressed this. So more than 500 600 plus cases series. So anywhere between 2 to 6% in different series you will find fistulation or penetration.
Yes, sir.
Okay, so this type of figure you will be ready if you have done the intensive reading part. Agar if you not done, then you will not be able to answer. Okay, so the
Okay, sir.
biggest problem here is that patient remained 1 year pain free. So that will be the strongest point against TB. Okay,
Okay, sir.
and watery diarrhea. How common is watery diarrhea in TB?
Sir, uh, like 60%, 40%, sir. 40%.
Okay. And why did you consider ileal lymphoma? Why not keep it like a small bowel lymphoma?
Sir,
There are two types of lymphoma commonly. What
yes,
are
sir.
those small bowel lymphoma when we talk of two types?
Yes, sir.
Common. What are those types?
Ileal and jejunal, sir.
नहीं वैसे नहीं क्लासिफाई करते हैं. क्लासिफाई करते हैं इप्सिड एंड नॉन इप्सिड या ईस्टर्न टाइप और वेस्टर्न टाइप.
Okay, sir.
ठीक है. ईस्टर्न टाइप इज इप्सिड. इप्सिड स्टैंड्स फॉर
Immunoproliferative small intestinal disease, sir.
हाँ, so small intestinal disease. Or western type is, so western is typically nodular, will involve a small distal small bowel, that is ileum, will be nodular involvement and typically will present with obstruction. And ipsid typically presents with chronic diarrhea.
Yes,
Long variable period of chronic diarrhea. So your patient had long period of
I my patient's age group and regionality goes against IPSID, sir. So that's why I didn't consider. Also,
रीजनलिटी में क्या प्रॉब्लम है इसकी?
sir, it
इंडिया
is.
इज द जोन. ईस्टर्न लिम्फोमा बोल रहा हूँ ना.
Yes,
So
sir.
India is the zone, Middle East is the zone for Eastern lymphoma. ठीक
Okay,
है.
sir. Yes, sir.
तो यही अंडर डेवलप्ड कंट्रीज ही तो ईस्टर्न लिम्फोमा के लिए टाइप है, इप्सिड के लिए है ना.
Yes, sir.
एंड टिपिकली इनिशियल पार्ट में इप्सिड पेनलेस होता है और बाद में सारे पेनफुल हो जाते हैं. इनिशियल पार्ट में देयर इज नो ऑब्स्ट्रक्शन एंड लेटर ऑन देयर बिकम्स ऑब्स्ट्रक्शन. So you should understand that where you keep Western type of lymphoma and where you keep Eastern type of lymphoma. Western type of lymphoma में कभी भी डायरिया डोमिनेंट सिम्टम नहीं होता है. डोमिनेंट या इसमें डोमिनेंट सिम्टम है ना.
Yes, sir.
ठीक है. सो वो नहीं रखते हैं कभी भी. और एनईटी
NET, so NET at ileum is the most common location of NET, sir. I've kept it last uh, uh, The points favoring are it most commonly presents with the bowel obstruction, weight loss, and diarrhea, sir. So,
Painless diarrhea.
yes, painful diarrhea, sir.
So commonly painful diarrhea because the obstruction उसमें common
Yes, sir.
होती है.
Yes,
So
sir.
that is relatively odd point. Painless diarrhea will be only if it is mediated by the
Carcinoid syndrome, sir.
हाँ कार्सिनोइड सिंड्रोम या अगर कोई वेजो एक्टिव सब्सटेंस प्रोड्यूस कर रहा है तो उसके साथ होता है, अदरवाइज नहीं होता है. चलो एक गो टू एग्जामिनेशन. वी हैव स्पेंट ऑलमोस्ट एन आवर ऑन दिस.
Yes. Examination, I'll proceed, sir.
या प्रोसीड टू एग्जामिनेशन.
So general examination, uh, positive finding, I'll comment and go, or should I tell everything, sir?
Everything.
Yes, sir. Is conscious, cooperative, oriented, time, place, and persons. So weight is 58 kg and BMF 20, pallor plus, no icterus, clubbing, lymphadenopathy, bilateral pitting bed edema, no external markers of tuberculosis, no external markers of GI malignancy, oral cavity, staining of teeth present, sir. Vital parameters are within normal limits, sir.
Okay.
Abdomen examination. Inspection abdomen is scaphoid, flanks are not full. Fullness is noted over right iliac fossa with a normal overlying skin. Becomes less prominent on leg raising test, prominent on lateral decubitus posture. Not moving with respiration with no cough impulse. No, all quadrants move equally with respiration. Umbilicus in midline inverted. No scar, sinus, visible veins, visible peristalsis or pulsations. Hernial orifices are free. And external genitalia are normal, sir. Palpation. Superficial palpation. There is no local rise of temperature or tenderness. On deep palpation, lump of size 80 to 6 centimeter is noted in right iliac fossa with a normal overlying skin, which is hard in consistency with smooth surface and ill-defined margin. It is tender on palpation with no guarding or rigidity. It is not moving with respiration with no intrinsic mobility, no pulsations. On leg raising test, it becomes less prominent with no cough impulse. There is no hepatosplenomegaly and all other inspectory findings are confirmed. Percussion dull note is noted over the lump with no shifting dullness. On auscultation, normal bowel sounds here, no bruit over lump. Per rectal examination, sphincter tone is normal, no mass, finger stained with yellow stools. Other systems examinations were normal.
Okay.
Syndrome at the end of the examination is chronic large bowel diarrhea with partial bowel obstruction. Contain perforation and intra-abdominal abscess, forming abscess, and the right iliac fossa intraperitoneal lump. Plane of the mass is intraperitoneal, sir.
Intraperitoneal. So how do you make a distinction between intraperitoneal, retroperitoneal, and parietal?
Sir,
So the lump can be in parietes, can be intraperitoneal, can be retroperitoneal.
yes, sir.
So how do you make a distinction?
On inspection, parietal swellings are usually prominent, sir, whereas intra-abdominal is vaguely defined and retroperitoneal may or may not be seen, sir. And on head raising test, parietal swellings become more prominent. Intraperitoneal becomes less prominent. Intraperitoneal and retroperitoneal becomes less prominent, sir. And on lateral decubitus position, which is used to differentiate between intraperitoneal and retroperitoneal lump, intraperitoneal falls forward, sir. Whereas retroperitoneal, it won't fall forward and there won't be any increase in prominence, sir. So these three features. And on percussion, intraperitoneal, it can be dull or it can be resonant. Whereas retroperitoneal, it is usually dull, sir. These four features, sir.
So this lump you feel it is intraperitoneal.
Yes, sir.
So and you find contain perforation. Contain perforation from where?
From terminal, eyes.
IC junction, cecum.
Cecum or terminal ileum, sir.
So cecum is intraperitoneal or retroperitoneal?
Cecum is intraperitoneal, sir.
Descending colon?
Retroperitoneal, sir.
Okay. ठीक है. So etiology, ileocecal tuberculosis. Ileocecal tuberculosis we discussed already that painless situation for going on for 1 year, that will be pretty odd. And weight loss is starting subsequently. And lymphoma, here you can consider Eastern type of lymphoma, also IPSI type of lymphoma. ठीक है, complication, malnutrition and anemia. ठीक है, it's mostly okay. ठीक है, so how will you investigate this patient?
My patient, I'll start with routine blood parameters. Complete blood count, I would order, sir. I would expect anemia. And renal function test I would do to look for hypokalemia since he's having loose stools. Also, any creatinine elevation I would like to see, sir. Note AK. Liver function test I would do, and I would expect hypoalbuminemia in this patient as he had lost significant weight. And inflammatory markers of ESR and CRP I would do, sir. And I expect elevated ESR and CRP in this patient. Next, I would do, since we are considering ileocecal tuberculosis, almost 25% have coexistent pulmonary tuberculosis. So I would do a chest X-ray to look for any associated cavitation or pleural effusion, sir.
And what percentage has pulmonary involvement?
25%, sir.
Active TB almost 1/4, and if you see active plus evidence of scarring and all, then possibly 1/3 to half can be having, so slightly higher.
Okay.
So that you have to expand the answer. That
yes,
active TB किसमें कितने percentage में होगी, तो that is how it can go. Okay.
Okay, sir. And then next,
few very important things you have missed out.
Okay, sir. I'll correct it, sir.
No, what are the things you missed out in early course? We did discuss, na?
Sir?
We discussed.
Yes, sir. Stool examination. Stool examination.
So very important, na? Because you are considering Crohn's disease, na? So you will like to see a stool exam, do a stool examination. What examination you will do?
Sir, since we are not very sure about osmotic secreted area, I look at the pH of the stool, sir. One thing. I also look for, since we...
at this stage, there is no point asking for pH, because here in differential diagnosis, you don't have anything. There can be pH, can be like carbohydrate malabsorption, and there can be because of carbohydrate malabsorption, you can pick up on the pH that it can be acidic, but that is not the issue out here. So no point talking that. Talk of the relevant thing.
WBCs and RBCs I look at, sir.
So because syndrome को confirm करना है ना कि it's still watery diarrhea or this is like inflammatory diarrhea, because जो भी आपने list out किया है ना, so virtually like TB will have inflammatory diarrhea, Crohn's disease will have inflammatory diarrhea, and आपका syndrome क्या है? Watery diarrhea. ठीक है, और आपने लार्ज बाउल वाटरी डायरिया होना है, तो लार्ज बाउल वाटरी डायरिया में टॉप ऑफ द लिस्ट क्या होता है?
सर
आईबीएस हो सकता है, वाटरी डायरिया, चलिए ठीक है, और
माइक्रोस्कोपिक कोलाइटिस, सर.
माइक्रोस्कोपिक कोलाइटिस. सो वो आपका डिफरेंशियल डायग्नोसिस में है ही है ना, तो सिंड्रोम और ये दोनों डिस्क्रिपेंट जा रहे हैं, दे आर नॉट कंकॉर्डेंट. ओके. So that's why when at the discussion stage I was pointing you out कि this is misconception that naked eye blood नहीं होगा तो उसको bloody diarrhea नहीं बनाएंगे. तो at this stage when you are asking for CBC, few things more you should have asked very early in the course. One is because you have given history of blood transfusion and iron infusion and those things. So you should have asked for the indices in the CBC and then also iron, B12 and folate level. Okay, because you have to manage the patient, na? So that is for management sake, not for the differential diagnosis.
Yes, sir.
So something can be urgency. If say for this patient has hemoglobin of 5 and then severe iron deficiency, you will like to give iron very early in the course, na?
Yes, sir.
So that is one. Second is stool examination. RE is okay. Microscopic examination you will do. but also fecal calprotectin, CRP, those things should be asked for very early.
Yes, sir.
Okay, so how do you send sample for fecal calprotectin?
Fecal calprotectin, sir, fresh sample will be sent to laboratory, sir.
So, सारे patients
Formed stools predominantly, sir. If it is
formed stool. वार्ड में बिल्कुल काम नहीं किया ना, सारा सारा नर्सेस को डेलीगेट कर दिया. ठीक है. So important है, because even if you delegate something to the nurses or hospital staff, na, you should be knowing, because you should be supervising that things are happening the way it should, or they are not happening the way it should be happening. Okay, so supervision के लिए आपको जानना जरूरी है, even if you are not doing. So you should know the fresh sample कहाँ से आएगा. ठीक है. सो ओपीडी के सारे पेशेंट्स आके वॉशरूम आपके यहाँ यूज करेंगे ना, तभी तभी देंगे ना फ्रेश सैंपल. मोस्ट पेशेंट डोंट डू लाइक दैट. वो तो घर से स्टूल पास करके आ जाएंगे, यहाँ जाएंगे वॉशरूम में, दे विल नॉट बी एबल टू पास. ठीक है. सो आपको पता होना चाहिए कि स्टेबिलिटी. से फॉर सम पेशेंट हैज ब्रॉट हिज सैंपल फ्रॉम द होम, विल यू एक्सेप्ट दैट और यू विल डिस्कार्ड दैट सैंपल?
I will accept that, sir.
उसने
It can,
24 घंटे
sir,
24 घंटे का पुराना स्टूल सैंपल लेके आया है.
it can be stored at room temperature up to 5 days, sir.
Up to 5 days. So that is because calprotectin is stable, and calprotectin is derived from what?
Neutrophil, sir.
Neutrophils. So ये stable protein है, so उसको काफी समय तक स्टोर कर सकते हैं. Say for what instruction you will give to the patient if you are asking them patient to get fecal calprotectin. Patient को कुछ instruction देंगे आप?
Sir, not sure, sir.
Not sure. Okay, ठीक है. ओके. अभी एक दूसरा क्वेश्चन यहाँ पे आता है जो मैंने बीच में बोला था कि आप क्लियरली यू शुड बी रेडी फॉर सर्टेन आंसर. उसमें देन आई मेंशन्ड दैट हाउ कॉमनली इज द पेरिटोनियल टीबी एंड इंटेस्टिनल टीबी occur together. Okay.
Yes, sir.
So here, because lump you are considering intraperitoneal lump, so it can be loculated ascites also. So
Yes.
that will raise that issue whether this is peritoneal involvement with intestinal involvement, or it is a complication of intestinal involvement. You understand? The
Yes,
two are different things. Okay, next investigation, what will you do?
Sir, I would do abdomen X-ray erect, sir. Since patient
Abdomen
is
X-ray, erect. Only
Yes, sir.
erect. Only erect. Only erect or erect and supine? Yes, supine.
Erect,
अभी अभी मैंने क्या कहा?
erect and supine, sir.
Erect and supine. So
Erect,
because
erect,
two is bigger than one, na? So that's why you opted?
erect, sir.
Because two is bigger than one, so that's why you opted, or there is some reason?
Sir, erect I would do to look at air fluid levels, whereas supine film I would I will do to measure the diameter, sir.
Diameter of what?
Diameter of colon, sir, transverse colon.
Transverse colon. इसमें transverse colon involvement आप suspect कर रहे हो? आप you are talking of ileocecal tuberculosis, Crohn's, carcinoma ascending colon, तो transverse colon diameter क्यों measure कर रहे हो?
Yes, sir.
नहीं. Explain me why you are measuring transverse colon diameter. Because none of your diagnosis involves involvement of transverse colon or left colon. So then why you are measuring diameter of transverse colon?
Yes, sir.
And then you are talking of perforation, and then you are not talking of pneumoperitoneum. So that is unpardonable, na?
Yes,
so
sir.
that will not be pardonable. So basically, the rule of thumb is said that supine X-ray is surgeon's X-rays. So surgeons basically look for two things: evidence of bowel obstruction in the form of air fluid level and evidence of pneumoperitoneum, that is evidence of perforation. दोनों सर्जिकल कॉज हो गया, सर्जन को ट्रांसफर हो जाएगा. Physicians are mostly concerned with the pattern of bowel gas. ठीक है, so pattern of bowel gas is always better seen in supine X-ray. So for better information, we almost always do twin, माने X-ray erect and X-ray supine. So one will show the air fluid level and pneumoperitoneum, and the other will show the gas pattern. Okay.
Okay, sir.
So if you have done endoscopy, say for colonoscopy, and then you are suspecting perforation, so which X-ray you will ask for? ये तो बड़ा क्रूड क्वेश्चन है ना
सर.
Which X-ray? Chest X-ray, abdominal X-ray erect, abdominal X-ray supine, both.
Sir, abdomen X-ray erect, sir.
Abdominal X-ray erect. It should be chest X-ray erect. ठीक है. So the best X-ray to look for pneumoperitoneum, the first one is chest X-ray. आज तक देखा कोई भी chest X-ray जिसमें right dome of diaphragm नहीं include हुआ हो?
Yes, sir. I've seen, sir.
You have seen?
Yes, sir.
Almost you will not see. Radiographer will be crucified if he prints any X-ray, chest X-ray without the right dome. ठीक है, बिकॉज वो लंग ही नहीं कवर कर रहा है. राइट डोम अगर लंग कवर कर रहा है तो राइट डोम ही कवर करेगा. तो इसीलिए ऑलवेज है कि इरेक्ट चेस्ट एक्सरे मांगना है, whereas abdominal X-ray may or may not cover you the dome of diaphragm.
Okay, sir.
ठीक है.
Yes, sir.
So that is a practical tip when you are working in the ward.
Yes, sir.
Okay.
Yes, sir.
So that is examiners. That is how examiner will test you, that how attentive you have been in ward. Okay, day to day.
Yes, sir.
Okay, ठीक है. नेक्स्ट इसका ये हो गया, अपना एक्सरे सिपाइन वो सारा गेम हो गया. अब एक्चुअल इन्वेस्टिगेशन पे आ जाते हैं.
Yes, sir. CECT abdomen with IV contrast I will do, sir.
IV contrast and oral contrast.
But since we are considering contain perforation in this, I will be happy only with IV contrast, sir.
अच्छा. So perforation is contraindication for oral contrast. Again, ward work, exam or presentation day is not the best day to make discoveries. So abdomen basically यहाँ पे क्वेश्चन ये नहीं था कि oral contrast देना है या नहीं देना है. The question for you was that you are going to give the neutral oral contrast or you are going to give positive oral contrast. You picked
Yes,
up
sir.
the wrong clue, completely wrong clue. ठीक है. So देना ही है contrast, because we use always use water soluble contrast. So perforation is not an issue with water soluble contrast, because that will go into peritoneum, will get absorbed. That is inconsequential because already lots of luminal content is flowing into the peritoneum. So the issue was whether you are going to use positive oral contrast or neutral oral contrast. So if you are suspecting perforation, almost always you will use positive oral contrast. And when you are suspecting bowel pathology, then you will do CT angiography, which is done with neutral oral contrast. ठीक है?
Yes, sir.
तो CT और MR.
Sir?
CT करना है कि MR करना है?
CT I will do, sir.
CT. Why CT?
CT
इंडियन गाइडलाइन है, इको का भी गाइडलाइन है. ठीक है, उसमें भी काफी अच्छा कवर किया हुआ है. इंडियन मल्टी सोसाइटी कंसेंसस गाइडलाइन है, उसमें भी कवर किया है स्मॉल बॉयल इमेजिंग इन सस्पेक्टेड आईबीडी पेशेंट्स. ठीक है. सो दोनों का गाइडलाइन में पढ़ोगे तो क्लियरिटी आ जाएगी कि सीटी करना है एमआर करना है. सो सीटी एंट्रोग्राफी वर्सेस एमआर एंट्रोग्राफी वी आर टॉकिंग अबाउट. ठीक है.
Yes, sir.
So both are comparable studies. There are few situations where MR is preferred. And what are those situations where MR is preferred?
Sir, if you have to differentiate between inflammatory versus fibrotic stricture, MR is preferred, sir.
उसके लिए कोई स्पेशल सीक्वेंस होता है? What is that special sequence called?
Fiesta, sir.
नहीं.
Diffusion weighted, sir.
हाँ, डिफ्यूजन वेटेड इमेजिंग. ठीक है, सो डिफ्यूजन वेटेड करते हैं. वो एक है. देयर आर मल्टीपल थिंग्स बट दैट इज वन ऑफ द मोस्ट इंपॉर्टेंट वन. So okay, that is one situation where we want to make a distinction between fibrotic versus inflammatory stricture. So okay, good. And what is other situation where we prefer MR?
Pediatric population where we have to do repeated scans, so in order to reduce the radiation exposure.
So where we expect multiple times imaging, particularly in pediatric situation, so there we will go for MR. So here you decided to go for CT.
Yes, sir.
Okay. So
yes,
again we revise with the positive oral contrast or neutral oral contrast or CT intrography. You said CT contrast CT abdomen, na? So contrast
yes,
CT abdomen is a different study and CT intrography is a different study.
Yes, sir. Sir, I would
because isme we are considering extra luminal pathology also because patient has lump, na?
Yes, sir.
Okay, so we will only CT intrography will not be suffice. So here we will go for CT abdomen, contrast CT abdomen with positive oral contrast because you are considering penetration or perforation.
Yes,
okay, so there we will do. Okay, I think we have covered most of it.
Okay,
and time is over, so I think we should stop here.